Bacterial endocarditis tells us exactly what the underlying problem is. There's some sort of bacteria invading or colonizing the heart and causing itis or inflammation. Be on the lookout for a patient with fever and cardiac exam abnormalities. So your first aid book says there is acute and subacute. Why would we differentiate the two? Well, there's going to be a difference in severity and the rate of progression. So acute endocarditis is a bigger problem because it's due to a highly virulent organism, Staph aureus. It is able to damage previously healthy valves because of an enzyme that it has that can break down hyaluronic acid, and this is hyaluronidase. Hyaluronic acid is highly expressed on heart valves. Endothelial cells are also present on heart valves. Staph aureus also has a toxin for this called leukocidin. Leukocidin causes direct endothelial cell necrosis because it inserts pores into the endothelial cells, causing them to lyse. So Staph aureus has no problem affecting completely healthy heart valves. How does the breakdown of hyaluronic acid by hyaluronidase and the lysis of endothelial cells by leukocidin lead to the creation of these vegetations that we see here in this image? Well, when you damage endothelial cells, you liberate von Willebrand factor and also factor VIII. Remember, von Willebrand factor carries factor VIII. So we liberate these things from the endothelium, and von Willebrand factor initiates the formation of platelet plugs, and factor VIII initiates the formation of a clot. The end result is that we have a big chunk of platelets and also fibrin. Staph aureus has no problem sticking to this. This is what creates the vegetation that we see here on the heart valve. The problem is that these vegetations don't stay there. They can dislodge and be liberated. When these are liberated, we have created septic emboli. We call it septic emboli because they're a combination of bacteria and thrombogenic stuff like platelets. Now, anywhere these emboli land can give the bacteria a new place to colonize and cause an infection or an abscess. The emboli can also occlude vessel lumens and cause infarctions of whatever vessel or tissue they land in. So let's talk about some specific locations where these septic emboli land and the related physical exam findings. Emboli can lodge in the retinal arterioles, causing very exudative, edematous hemorrhagic lesions, which we call Roth spots. They can also lodge in the arterioles of the palm or sole, causing very painful nodules, which we call ostler nodes. And here we can see these ostler nodes, here and here, on the bottom surface of the foot. They're very purple, and there's a difference between these and the other lesions that are painless. We'll get to those in a second. We may also see these bad boys. These are splinter hemorrhages. This occurs from emboli occluding the tiny arterioles of the nail bed. So emboli can also be distributed into the vasculature of the palm or soles, causing painless erythematous lesions, which we call Janeway lesions. If the vegetations are occurring on the tricuspid valve, they can actually break off and enter in the pulmonary vasculature and cause pulmonary emboli. So what are some other physical exam findings we should be looking for? Well, whenever we have a damaged valve, we can cause a new onset murmur. What about the anemia that we can potentially see in these patients? Can anyone explain this? Well, the answer is in your hematology section. This is anemia of chronic disease. Our body has an adaptive process of responding to any sort of inflammation anytime our immune system is activated because it will start producing inflammatory mediators such as hepcidin, and hepcidin's job is to downregulate available iron, and this leads to anemia of chronic disease. So how does Staph aureus even get access to the heart? The number one reason is IV drug use. Why? Well, the same reason that IV drug users also get Pseudomonas and Candida. These organisms can exist on your skin at any point in time. When you shove a needle into your vein, you're going to introduce these organisms directly into your bloodstream from the skin. And the tricuspid valve is the valve most often damaged because it's the first to receive contaminated venous blood in IV drug users. It is important to note that the most commonly affected valve in general, not IV drug users, is the mitral, not the tricuspid valve. So now that we discussed acute endocarditis caused by Staph aureus, we will move on to understanding subacute, culture-negative, and non-bacterial. So subacute endocarditis is a more indolent process. It takes a longer time to progress to symptoms because it is due to a lower virulent organism. This is Viridans streptococcus. It does not have all of the enzymes and toxins like Staph aureus does. In fact, it can't even infect a normal healthy valve like Staph aureus can. It needs a previously damaged valve. Where would we see previously damaged valves? How about in a patient that has a history of rheumatic fever, mitral valve prolapse, calcified valves, a bicuspid aortic valve, or even someone that has a synthetic surface in their heart that is particularly easy to stick to, such as a prosthetic heart valve? So how is viridans streptococcus going to get into the blood to begin with? It is commensal in our oral cavities in addition to the HASEC organisms as well. Something as simple as a dental procedure causing some bleeding from your gums is enough for the bacteria to gain access via one of the damaged capillaries in your gums. That's why patients with prosthetic heart valves get prophylactic antibiotics at the dentist. That's under some question these days, but don't stress about that. Now, in your book, it also says that people with colon cancer can get bacterial endocarditis by Streptococcus bovis. Why? Well, Streptococcus bovis is a commensal in the colon. If someone has a malignant tumor in their colon, there's going to be tons of ulceration and bleeding within the colonic mucosa. This gives Strep bovis perfect access to the bloodstream, and that's exactly how it's going to make it to the heart. Now what about Staphylococcus epidermidis? Staph epidermidis is everywhere on the skin, hence the name epidermidis. It is classically associated with any foreign device that we have to touch with our hands to put into the patient's body. Watch out for this in a patient with a prosthetic heart valve. Okay, so what about this culture-negative bacterial endocarditis? There are organisms causing this endocarditis, but your culture medium just cannot grow it. The classic ones are Coxiella burnetii and Bartonella. Remember, these are intracellular organisms and will not grow on the medium. How will you know if these two are the etiology of your endocarditis? Well, if it's Coxiella, be on the lookout for some sort of hint, such as unpasteurized milk or cheese. And if it's Bartonella, then be on the lookout for a patient that particularly loves cats. Remember, it causes cat scratch fever. The other culture-negative results can be due to the HASEC organisms. These are Haemophilus, Actinobacillus, Cardiobacterium, Eikenella, and Kingella. These guys have very strict growth requirements and just don't grow on routine blood cultures. The truth is that the blood cultures we have nowadays will grow out all of these, but prior mediums, when they named these things, did not. So what are some of the complications of endocarditis? Well, the bacteria can cause inflammation of the chordae tendineae, and rupture of the chordae tendineae can lead to new onset murmurs. So we can rupture these, and now we have new murmurs. The bacteria can extend from within the myocardium into the pericardium. This causes an infection in the pericardial sac, which we call suppurative pericarditis. Lastly, but also important, is the potential for glomerulonephritis. When your immune system decides to ramp up an antibody response against the bacteria, these antibodies are going to bind bacterial antigens and create immune complexes. So here's your antigen attached. What is the kidney going to do? These complexes are too big to be filtered into the urine, and they're going to start depositing on the glomerular basement membrane. Immune complexes stuck on the glomerular basement membrane are then going to activate complement, and this is going to lead to inflammation of the glomerulus, which creates glomerulonephritis. Okay, now we move on to the stuff that doesn't have anything to do with bacterial infection. Non-bacterial endocarditis, sometimes called morantic or thrombotic, is secondary to a malignancy, a hypercoagulable state, or systemic lupus erythematosus. Now, malignancy and hypercoagulable state, or even lupus, should all be grouped together because all of these are a propensity to create clots. Now remember that tumors can produce anything, including clotting factors or tissue factor. A particularly high yield type of tumor, though, is a mucinous cystadenocarcinoma. These tumors are cysts made up of adenomatous cancer cells that produce tons of mucus. So fibrinogen and platelets see all this mucus and they start sticking to it. And this is how we can initiate a clot. This is going to help you get the correct answer, so listen up. These sterile emboli tend to get stuck on the inferior side of heart valves. So we should be looking here on the inferior side. This is the superior side of the heart valve. So these sterile emboli tend to be on the inferior side of heart valves, as opposed to bacterial emboli, which tend to be stuck on the superior side. What would you be thinking about if they told you that there was a vegetation on both sides of the heart valve? This is one of the few times where you can guess lupus and be correct. So let's talk a little bit more about lupus. Let's resume there. Remember, lupus is an autoimmune disease in which the body forms antibodies to many different types of cells because the problem is clearing cell contents in apoptosis. This means that any cell component can be abnormally disposed of, and if the immune system gets a hold of one of the self-antigens, it's going to start producing antibodies against it. You can guarantee that we're going to get tons of antibodies created against lots of different self-antigens. I remember it in cardiology because one of the antibodies found in lupus patients is anti-cardiolipin. Anti-cardiolipin is an autoantibody formed against cardiolipin that's found in all animal hearts. Now, these antibodies are going to stick to both sides of the heart valves. Why? Well, the antigens that it's targeting are present on every single part of the heart valve. Do not expect to have the classic buzzword, Liebman-Sachs endocarditis. You need to know that these vegetations will be formed on both sides of the valve because that's how they will be described to you. No more eponyms. All right, here we go with the flash quiz. Describe the time period of CKMB elevation after an acute myocardial infarction. When you think about cardiac markers, always remember that troponin I is the most specific, so any questions about CKMB should make you think that they're asking you about reinfarction. So here's the answer. CKMB peaks at 1 day after a myocardial infarction, and it's absent by day 3 unless there's reinfarction. This is super important. It's a helpful tool in trying to determine if your patient suffered another infarction.